Good morning and welcome everybody to this today's class. And my today's topic is coronary blood flow and myocardial ischemia. Now, with the permission of Sir, I am going to present my lecture. Next. The coronary circulation refers to the vessels that supply and drain the heart, and coronary arteries are named as such due to the way they encircle the heart, much like a crown. An arterial circle surrounds the heart in coronary sulcus, and from this arterial circle, an arterial loop runs in the anterior and inferior interventricular groups. Next. The arterial supply of the heart is mostly supplied by two coronary arteries, which originate from the ascending aorta immediately above the aortic valve from the aortic sinus. The coronary arteries and their branches run on the surface of heart, being located inside the subepicardial fibropathy tissue. Subpericardial fibropathy tissue. And next. This is the relationship between aortic sinus, coronary sulcus, the right atrioventricular opening, and from the aortic sinus, both left and right coronary arteries are arising. It is shown here. And next. This is also the origin of the coronary arteries from the right and left aortic sinuses. And blood ejected from the left ventricle forces the cusps apart, and in the last, when the valve closes, the nodules and lineoles meet in the center, and blood is backflow. There is backflow of the blood occurs. And coronary arteries, there are two main coronary arteries which branches to supply the entire heart. They are named the left and right coronary arteries and arise from the left and right aortic sinuses within the aorta. The aortic sinuses are small openings found within the aorta behind the left and right flaps of aortic valves. And when the heart is relaxed, the backflow of blood fills these valve pockets, therefore allowing blood to enter the coronary arteries. Now, characteristics of coronary arteries. The coronary arteries are vasa vasorum of the ascending aorta, and anatomically coronary arteries are not end arteries, and functionally they become like end arteries. The only branches of ascending aorta are coronary arteries, and the only arteries which get filled up during diastole of the heart. This is a diagrammatic picture which shows there is right posterior surface is supplied by posterior left ventricular artery, and there is anterior interventricular artery and left anterior descending artery. And anterior supply surface is mostly supplied by right coronary artery and mainly by right marginal artery, and also left coronary artery mainly by left anterior descending and left marginal artery, and left posterior surface is mainly supplied by circumflex artery. This is the anterior view of arterial system, showing the right and coronary artery, their courses and branches. This is the posterior view, shows the main arteries supplied to the heart, then right and left coronary artery branches, circumflex artery and atrioventricular branches, and I will discuss this later. The left coronary artery, the left coronary artery, which is usually larger than the right coronary artery, which supplies the major part of the heart and includes the greater part of the left atrium, left ventricle, and interventricular septum. The left coronary artery originates from the left posterior aortic sinus of the ascending aorta. Now shortly, the course of the left coronary artery. After arising from the ascending aorta, the left coronary artery runs forwards and to the left between the pulmonary trunk and left auricle. It then divides into an anterior interventricular and circumflex artery. The anterior interventricular artery, which is also called left anterior descending artery, runs downwards in the anterior interventricular groove to the apex of the heart. It then enters posteriorly around the apex of the heart to go into the posterior interventricular groove to terminate by anastomosing with the posterior interventricular artery, which is a branch of right coronary artery. Then circumflex artery winds around the left margin of the heart and continues in the left posterior coronary sulcus up to the posterior interventricular groove, where it ends by anastomosing the right coronary artery. Now, branches and distribution of the left coronary artery. First one is anterior interventricular or left anterior descending artery, which supplies the anterior part of the interventricular septum, greater part of the left ventricle, and part of right ventricle, also a part of left bundle branch. And circumflex artery, it supplies the left marginal artery that provides the left margin of the left ventricle up to the apex of the heart. And diagonal branch, it may originate directly from the trunk of the left coronary artery. And conus artery, it supplies the pulmonary conus. And there is atrial branches, they supply the left atrium. And it is shortly shown the area supplied by the left coronary artery. I already mentioned it summarizes the left atrium, left ventricle, except the area adjoining the posterior interventricular groove. The right ventricle adjacent to the anterior interventricular sulcus, anterior two-thirds of the interventricular septum, as a node in 35% of cases, and part of the left branch of bundle of His. Now the right coronary artery, it arises from the right aortic sinus of the ascending aorta. It passes to the right of the pulmonary trunk and runs along the coronary sulcus before branching. And near its origin, the right coronary artery usually gives off an ascending cyanoatrial nodal branch which supplies the SA node, and the right marginal artery arises from and moves along the right and inferior border of the heart towards the apex. The right coronary artery is angiographically divided into three segments: first segment, second segment, and third segment. First segment is from the origin to the first curve and passes forward for a distance between pulmonary trunk to its left and the right auricle to its right. And second segment, it is first curvature to a second curvature. It is second segment and lies in the anterior part of atrioventricular groove. And third segment, it extends from the second curve to the crux cordis. Next one. The branches of the right coronary artery, and early atrial branch passes in the groove between the right auricle and ascending aorta. The cyanoatrial branch, the right marginal branch, is given up as the right coronary artery approaches the inferior margin of the heart and continues along this border towards the apex of the heart. A small branch to the atrioventricular node before giving up its final major branch, the posterior interventricular branch, which lies in the posterior interventricular sulcus. The areas supplied by the right coronary arteries, the right atrium and right ventricle, the cyanoatrial and atrioventricular nodes, the interarterial septum, portion of the left atrium, the posterior inferior one-third of the interventricular septum, and a portion of the posterior part of the left ventricle. Now, what is dominance? The coronary dominance is based on the vessel that gives rise to the posterior descending artery, which supplies the atrioventricular node. Recognized by the presence of septal perforating branches, arises from the right coronary artery in 80 to 85% of cases, and from the left coronary artery, which is from the left circumflex artery, in about 10% of population. And codominance is found in 10% of the population, where the posterior interventricular artery is formed by both the RCA and LCX. this is shown the right dominance. The posterior interventricular artery is a branch of right coronary artery, and in the left dominance, it is a branch of left coronary artery. This is shown here. So, in dominance, left dominance blocks in left coronary artery, and it affects the entire left ventricle and interventricular septum. So, it is a fatal condition if the left dominance occurs, but in the right or balanced dominance, block in RCA at least spares part of septum and left ventricle. And in a study, it shows that the left dominance coronary artery system blockage, there is significant risk of 30-day mortality and early reinfarction after ST elevation MI. But after 30 days, the outcome is same for the right and left dominance. And this is a box which shows the area supplied by different coronary arteries and their branches. And next, and there is coronary artery anastomosis. And this is anastomosis between the terminal branches of the right and left coronary arteries. It is collateral circulation. It exists, but they are usually not large enough to provide an adequate supply to the cardiac muscle should one of the large branches become blocked by a disease. A sudden block of one of the larger branches of either coronary artery usually leads to myocardial death, although sometimes the collateral circulation is enough to sustain the muscle. Now, the summary of overall arterial supply to the heart in most individuals. The right coronary artery supplies all the right ventricle except for a small area to the right of anterior interventricular group, the variable part of the diaphragmatic surface of the left ventricle, the posterior inferior third of the ventricular septum, the right atrium, and part of the left atrium, and SA node and AV node, and left bundle branch also receives small branches. The left coronary artery supplies most of the left ventricle, small area of right ventricle to the right of the interventricular groove, the anterior 2/3 of the ventricular septum, most of the left atrium, right bundle branch, and the left bundle branch. And the coronary veins, it is missed here, and I am presenting this. There are main three coronary venous system. There is coronary sinus, anterior cardiac vein, and vena cordis minimi or Thebasian vein. You already know that the coronary sinus drain blood from the myocardium to right atrium, and there are tributaries of coronary sinus are great cardiac vein, small cardiac vein, middle cardiac vein, right marginal vein, posterior vein of left ventricle, and oblique vein of left ventricle. And there is also anterior cardiac vein, which drains from right ventricle to right atrium. And Thebasian or vena cordis minimi, the coronary luminal vessels forms deep venous system, which is called vena cordis minimi. And all the heart valve, all the veins have valves except oblique vein of the left atrium. And now there are some anomalies in coronary arteries. Sometimes the left coronary artery arises from the pulmonary trunk, which causes cyanosis. And left coronary artery sometimes arises from the right aortic sinus, and it may get compressed between the pulmonary trunk and aorta in strenuous exercise and may cause sudden cardiac death. And cyanoatrial nodal branch may arises in 40% cases from the circumflex artery, and avinodal artery may arises in 20% cases from the circumflex artery. These are the anomalies of the coronary arteries. Now, coronary blood flow. A continuous flow of blood to the heart is essential to maintain an adequate supply of oxygen and nutrients. The resting coronary blood flow in the resting human being averages 70 ml per minute per 100 gram of heart weight, or about 225 ml per minute, which is about 4 to 5% of the total cardiac output. And 3 to 6-fold increase in the coronary blood flow may occur during exercise. Oxygen consumption by the myocardium is very high, that is 8 ml per minute per 100 gram at rest. Because of this, even at rest, 70 to 80% of the oxygen is extracted from each unit of the coronary blood as compared to the whole body, averages 20-25% oxygen extraction at rest. The increased oxygen demand of the myocardium during exercise is met with by almost total extraction of oxygen and by manifold increase in the coronary blood flow. This shows the coronary blood flow during systole and diastole. During diastole, the blood flow increased markedly. Phasic blood flow. During systole, the tension developed in the left ventricle is so high that it has throttling effect on the branches of the coronary arteries, penetrating through them. As a result, the average blood flow through the capillaries of left ventricle falls to the extent that during isometric contraction phase, the blood flow to the left ventricle practically ceases. It becomes almost zero. During diastole, the cardiac muscles relaxes and blood flow increases, thus most of the coronary blood flow, about 70%, occurs during diastole. This is the this shows epicardial coronary arteries and subendocardial arterial plexuses. And next, subendocardial region of the left ventricle receives no blood supply during systole. So this region is particularly vulnerable to ischemia and is the most common site of myocardial infarction. Minimum diffusion distance between the capillaries and myocardial cells is 20% shorter in the subendocardial region of left ventricle as compared to the epicardial region. And myoglobin content is higher in the subendocardial region than the epicardial region of the left ventricle. This is true in spite of the fact that this region has been provided with following compensatory mechanisms. Capillary density in subendocardial region of the left ventricle is much higher than the epicardial region. The coronary blood flow shows changes during phases of the cardiac cycle. The blood flow is determined by the balance between pressure head, such as aortic pressure, and the resistance offered to the blood flow during various phases of cardiac cycle. Now, measurement of coronary blood flow. There is some old methods, and you have read it in second year in Guyton, and this is a nitrous oxide method, which is based on Fick's principle. It is the most common method used for measuring coronary blood flow. Next. And this is a procedure. I think it is not necessary, but you can read it in later. And next. The coronary blood flow is determined in this process from the amount of nitrous oxide taken up per minute and the difference of nitrous oxide content of arterial and venous blood. Next. Another one is radionuclides utilization technique. And distribution of radioactive tracers is directly proportional to myocardial blood flow, and this forms the basis of this technique. Next. Now, newer methods are coronary angiographic techniques. Coronary angiography and the electromagnetic flow meter. and a electromagnetic thermometer is practically employed in animals to measure the coronary blood flow. Next. Now, regulation of coronary blood flow. There is autoregulation. The circulation shows well-developed phenomenon of autoregulation, which is 60 to 200 millimeter mercury. Next. And role of local metabolites. The metabolic local factors are the most important factors which regulate the coronary blood flow. Direct effect of oxygen. It has been proposed that a decrease in the tissue partial pressure of oxygen could also act directly on the arterioles and cause vasodilation. And oxygen demand is a major factor in local coronary blood flow regulation. Role of adenosine. This is Barnes' hypothesis. Adenosine is considered the major factor in production of coronary vasodilation during hypoxic states. In myocardial ischemia, either due to generalized hypoxia or due to increased myocardial metabolism, the intracellular myocardial adenine nucleotides are degraded to adenosine. The adenosine is capable of crossing myocardial cell membrane, producing an extremely strong vasodilator response. Role of other local metabolites, hydrogen ion, bradykinin, carbon dioxide, and prostaglandins are other suggested vasodilator substances. Now, nervous control mechanism. Autonomic nerves control the coronary blood flow directly as well as indirectly. Direct nervous control. Parasympathetic nerve fibers to coronary vessels through vagus are so less that the parasympathetic stimulation has very little direct effect, causing vasodilation. Sympathetic nerve fibers extensively innervates the coronary vessels. The transmitters released at their nerve endings are epinephrine and norepinephrine. The coronary vessels contain both alpha and beta receptors. The net result of direct effect of sympathetic stimulation is vasoconstriction. Indirect nervous control. Sympathetic stimulation causes increase in the heart rate and increase of force of contraction of the heart. Thus, an increased activity of heart helps conversion of ATP to ADP, which by producing coronary vasodilation increases the coronary blood flow. Next. And parasympathetic stimulation causes decreased heart rate and decreased force of contraction of heart. Thus, indirectly, the coronary blood flow is reduced. Now, factors affecting coronary blood flow. Mean aortic pressure. This is the force for driving blood into the coronary arteries. Rise in mean aortic pressure increases the blood flow and vice versa. Emotional excitement. During emotional excitement states such as fright, auditory, and olfactory stimuli, the coronary blood flow is increased due to increased sympathetic discharge. Muscular exercise. Normal coronary blood flow at rest is about 70 ml per 100 gram tissue per minute. During exercise, coronary blood flow increases about 4 times because of sympathetic stimulation by the following mechanisms: increased activity of the heart, increased cardiac output, and increased in mean arterial pressure. Hypotension. There occurs reflex increase in noradrenergic discharge during hypotension, which produces coronary vasodilation to increase coronary blood flow. This effect is observed secondary to the metabolic changes in the myocardium at a time when there occurs vasoconstriction of splanchnic, renal, and cutaneous vessels. Hormones affecting coronary blood flow are thyroid hormones increases coronary blood flow because of increase in metabolism. Adrenaline and noradrenaline causes increase in blood flow indirectly. Acetylcholine may increase blood flow by its action on heart, similar to parasympathetic stimulation. And pitressin is known to decrease blood flow by increasing coronary resistance. Nicotine is reported to increase blood flow through the liberation of norepinephrine. When When heart rate is increased, stroke volume decreases, therefore phasic blood flow and oxygen consumption per beat also decreases. Effect of ions. Potassium ions in low concentration causes dilatation of coronary vessels, increasing coronary blood flow, whereas high concentration of potassium causes constriction of coronary vessels, decreasing the coronary blood flow. Metabolic factors. Increased metabolism of the heart increases oxygen consumption, leading to relative hypoxia. Hypoxia causes vasodilatation due to direct effect and also due to release of adenosine, leading to increased coronary blood flow. Hyperthermia increases metabolism and so causes increase in coronary blood flow, and hypothermia decreases metabolic rate and decreases the blood flow. Now, this is myocardial ischemia. You have already know extensive classes regarding myocardial ischemia, STMI, non-STMI, unstable angina, stable angina have already finished, and you all students have already gained much knowledge about this. Now it is actually retrograde lecture, and basic of the coronary artery disease I am going to present. And coronary artery disease, it is also known as ischemic heart disease, and resulting due to the insufficient coronary blood flow. And it is a condition associated with development of atherosclerosis in the coronary arteries, which supplies the heart muscle. With atherosclerosis, the arterial wall is hardened and its lumen becomes narrow due to plaque formation. And angina pectoris, you know well that angina pectoris is a transient form of myocardial ischemia, especially occurring during increased oxygen demand in patients with coronary artery disease, having about 60 to 70% narrowing of coronary arteries. And superadded thrombus formation causing incomplete coronary occlusion results in an unstable angina. Characteristic features. Typically, the angina is described as a feeling of uncomfortable pressure, fullness, or squeezing or pain in the substernal region, which may be localized or may be referred to the inner border of left arm, neck, or jaw. Pain occurs due to accumulation of anoxic myocardial metabolites and factor P, which stimulates pain nerve endings. This is a picture showed the ischemic and non-functional and dead fibers in the myocardium, and dead fibers occurs in the myocardial infarction, and fibrous tissue ultimately made. And myocardial infarction or acute myocardial infarction, commonly known as a heart attack in general population, and refers to a degree of myocardial ischemia due to interruption of blood supply that causes irreversible changes, that is necrosis, cell death, or infarction in the myocardium. Signs and symptoms. Sudden severe chest pain is a classical symptom of myocardial infarction, and pain lasts for more than 30 minutes and typically may radiate to the left atrium and left side of the neck. Pain occurs due to the anoxic metabolites and necrotic tissue products, and associated symptoms with pain often complained by patients are shortness of breath, nausea, vomiting, palpitation, sweating, and anxiety, often described as a sense of impending doom. Approximately 25% of all myocardial infarction are silent without chest pain or other symptoms. Silent MI usually occurs in diabetics with associated autonomic neuropathy in elderly. Diagnosis of MI is made by triad of typical signs and symptoms associated with ECG changes seen on serial tracing and changes in serum levels of certain enzymes and proteins. আমি এগুলো নিয়ে ডিটেল যাব না, ডিটেল অলরেডি বিভিন্ন ক্লাসে আলাপ করা হয়েছে। এখন coronary still syndrome, there is value of rest in treating myocardial infarction. The degree of cardiac cellular death is determined by the degree of ischemia and the workload on the heart muscle. when the workload is greatly increased, such as during exercise in severe emotional strain, the heart needs increased oxygen and other nutrients for sustaining its life. Collateral circulation, life-saving value of collateral circulation in the heart. The degree of damage to the heart muscle caused either by slowly developing atherosclerotic constriction of the coronary artery or by sudden coronary occlusion is determined to a great extent by the degree of collateral circulation that has already developed or that can open within minutes after the occlusion. So collateral circulation is very much important. And furthermore, the anastomotic blood vessels that supply blood to ischemic areas of the heart must also still supply the areas of the heart that they normally supply. When the heart becomes excessively active, the vessels of the normal musculature become greatly dilated. This allows most of the blood flowing into the coronary vessels to flow through the normal muscle tissue, thus leaving little blood flow to flow through the small anastomotic channels into the ischemic area, so that the ischemic condition worsens. This condition is called coronary still syndrome. And আমি আর এর চেয়ে বেশি যাচ্ছি না মায়োকার্ডিয়াল ইস্কেমিয়াতে। And thank you all.
Thank you, sir, for a nice class, sir.
এই করোনারি স্টিলটা পরীক্ষার সময় জিজ্ঞাসা করে তো, এটা একটু আরেকবার একটু ওদেরকে একটু বলেন করোনারি স্টিলটা। এর মেকানিজম জিজ্ঞাসা করে।
কামাল
দেওয়া আছে স্যার।
এটা আসলে
স্লাইড দেখতে পাচ্ছেন স্যার?
হ্যাঁ
আমরা দেখতে পাই তো।
এখন এটা হচ্ছে যে মানে যখন ওয়ার্কলোড বেড়ে যায় হার্টে, during exercise or severe emotional stress, the heart needs increased oxygen and other nutrients for sustaining its life. Next. And the degree of damage to the heart muscle caused either by slowly developing atherosclerotic constriction or by sudden coronary occlusion is determined by degree of collateral circulation that has already developed or that can open within minutes after the occlusion. যেটা যে collateral circulation আছে সেটা মানে তার মানে degree of collateral circulation তার ইয়াটা বেড়ে যায়, অ্যাক্টিভিটিসটা বেড়ে যায়। নেক্সট। The anastomotic blood vessels that supply blood to ischemic areas of the heart must also still supply the areas of the heart that they normally supply. সে নর্মালি যে এরিয়াটাকে সাপ্লাই দিচ্ছে তাকেও সাপ্লাই দিতে হচ্ছে, আবার যে জায়গাটা ইস্কেমিক হয়ে গেছে তাকেও সাপ্লাই দিতে হচ্ছে। যার ফলে when the heart becomes excessively active, এটা আসলে যখন মানে অ্যাক্টিভিটিস বেড়ে যায়, the vessels of the normal musculature becomes greatly dilated. The normal musculature-ও dilated হয়ে যায় ভেসেলগুলা, তখন ওইখানে আবার ব্লাড ফ্লো বেড়ে যায়। যার ফলে the coronary vessels blood flow into the coronary vessels to flow through the normal muscle tissue, thus leaving little blood flow through the small anastomotic channels. তখন anastomotic channel-এ blood flow-টা কমে যায়, so the ischemic condition worsens. This is called coronary still syndrome. বুঝছেন কিনা? কারণ একটা ইস্কেমিয়া হয়ে গেলে তার যে ওই অ্যানাস্টোমেটিক চ্যানেলগুলা ডাইলেট হয়ে যায় এবং এটা যে নর্মাল টিস্যুকেও সাপ্লাই দেয় এবং ইস্কেমিক টিস্যুকেও সাপ্লাই দেয়। কিন্তু যখন ইস্কেমিয়ার মধ্যে যখন স্ট্রেসফুল ইভেন্টগুলা হয় তখন তার মানে ইয়াটা ওই যে মাস্কুলেচার গুলা যে ভেসেল থাকে ওই ভেসেল গুলো ডাইলেটেড হয়ে যায়, যার ফলে ওই ভেসেল গুলো ওই মাসলকে বেশি বেশি সাপ্লাই দিতে হয়। আবার ইস্কেমিক ভেসেলে তখন কোলাটারাল সাপ্লাইটা কমে যায়, যার ফলে এই ইস্কেমিয়াটা ওয়ার্স হয়ে যায়। আর বুঝছেন কিনা?
জি স্যার।
পরীক্ষার সময় এটা জিজ্ঞাসা করা হয়, করোনারি স্টিল সিনড্রোম বলতে কি বুঝো? প্রিফারেন্সিয়াল ডাইলেটেশন হয় এবং ইসকেমিক জোন সাফার করতে থাকে, এজ এ হোল সমস্ত জায়গায় সাপ্লাই যায়, সেই জন্য হয়। আর কোশ্চেন থাকলে বলেন, নাকি আমি নাই?
স্যার আপনি আছেন।
আমি তো আছি মনে হইতেছে। আমি তো হটস্পট দিয়ে চালাইতেছি, মাঝখানে চলে গেছিলাম।
আসলে বেসিক জিনিস, ওটা মানে তো ইন্টারেস্ট তো নাই বেশি।
না, এটা অনেক জানার ব্যাপার তো। ওই যে পটাশিয়াম, মানে ওই যে হাইপার ক্যালেমিয়ায় কেন কার্ডিয়াক অ্যারেস্ট হয়ে যায়, মানে বেশি পটাশিয়াম থাকলে, এবং এটা যে ভ্যাসোকনস্ট্রিকশন করে, এটা জানা দরকার। খুবই ইম্পর্টেন্ট, অনেকগুলো ইম্পর্টেন্ট কথা মানে আছে। করোনারি সার্কুলেশন এবং ওই পেশেন্টের, প্রত্যেকটা পেশেন্টের মানে এমআই হওয়ার পরে প্রেজেন্টেশন কিন্তু একরকম থাকে না। কারো খুব বেশি প্রেজেন্টেশন থাকে, কারো মাইল্ড প্রেজেন্টেশন থাকে, কারো এই মুহূর্তের মধ্যেই মরে যায়, কেউ কোনো সমস্যাই হয় না। এগুলো ডিপেন্ড করে তার এই যে সার্কুলেশনের উপরে, ব্লকটা কোথায়, কত পার্সেন্ট ব্লক, এবং কোলাটেরাল সার্কুলেশনটা কিভাবে তার এস্টাবলিশড হতে পারছে তার উপরে। যদি খুব র্যাপিডলি কোলাটেরাল সার্কুলেশন ডেভেলপ হয়ে যায়, তাহলে সেটা ভালো থাকে সাপ্লাইটা। কোলাটেরাল ডেভেলপ না করলে তো পেশেন্ট মানে হয়ে যায়, খারাপ হয়ে যায়, খুব তাড়াতাড়ি খারাপ হয়ে যায়। খুব বেসিক মানে ফারুক, আপনার অনেক ধন্যবাদ। অনেকগুলো বেসিক জিনিসগুলো মানে আপনি সামনে নিয়ে আসছেন। বেসিক কনসেপ্ট আসলে ওই যে বিল্ডিং তৈরি করতে গেলে যেমন আপনার বেসমেন্টে খুব ভালো ঢালাই লাগে, নতুবা বিল্ডিং দাঁড়ায় না। এজন্য আপনার যত বেসিক ভালো থাকবে, আপনার ফিজিওলজি এবং প্যাথোলজি এবং ক্লিনিক্যাল সাইডটা আপনার বুঝতে খুব ইজি হবে, আন্ডারস্ট্যান্ডিংটা খুব ইজি থাকে। এই জন্য বেসিক
আর্টেরিয়াল ফোর্সটা স্যার খুব ইম্পর্টেন্ট। আর্টেরিয়াল ফোর্স আর ব্রাঞ্চ গুলা, ডিস্ট্রিবিউশন,
করোনারি ব্লাড ফ্লো, এগুলো বুঝতে মানে যদি পারা যায়, তাহলে ইসকেমিয়া বা ইসকেমিক রিলেটেড যে ইভেন্টস গুলো আছে, এগুলো সম্পর্কে করা যায়। এগুলো আসলে আমরা এতটা মানে দিয়ে কখনোই পড়ি নাই, কিন্তু কোশ্চেন তো চলে আসবে। এইখানেই ওই যে করোনারি স্টিল যে আছে, বঙ্গবন্ধুতে দেখলাম যে কোশ্চেনের আছে ওদের, ওই যে রিটেনে যে ছোট ছোট যে কোশ্চেন গুলা থাকে 2, 3, 5, তার মধ্যে এটা করোনারি স্টিল একটা কোশ্চেন দিয়েছে, হোয়াট ডু মিন বাই করোনারি স্টিল বা করোনারি ব্লাড ফ্লো, হোয়াট আর দি ফ্যাক্টরস দ্যাট ডিটারমাইন করোনারি ব্লাড ফ্লো। এটা মানে ওখানে দাঁড় করাই দিতে পারে হাইস্টেট যে কোশ্চেন থেকে। ঠিক আছে, যদি কোশ্চেন থাকে তাহলে করেন, আর যদি কোশ্চেন না থাকে তাহলে আমরা করব, লিভ করতে চাই। আজকে তো লকডাউন শুরু হলো প্রথম। তাহলে সবার আগে আমি ফারুক তোমারে অনেক ধন্যবাদ দিই যে তুমি খুব একটা কঠিন একটা সাবজেক্টকে সবার সামনে আসলে উপস্থাপন করছো। এটা আমাদের অনেকেরই জানা নাই, আমরা এটা আসলে অনেক জিনিসগুলো এটা আজকে জানতে পারছি। হ্যাঁ, সবাইকে ধন্যবাদ, সবাই ভালো থাকেন, আর দেখেন কি অবস্থা দেশের।